Now, today we are going to discuss about erythroplakia. It is first reported in 1911 in the patient on the gland penis in Korea. So, it is basically red lesion or red patch or plaque in oral mucosa, which can't be characterized clinically or pathologically as any other condition and which has no apparent cause, right? So it is basically a red lesion as compared to leukoplakia, which was a white one. It is a red lesion and are large heterogeneous group or disorder of the oral mucosa. So basically, erythroplakia is a solitary red lesion as well as pre-malignant lesion in the oral cavity. Just remember, it is a pre-malignant lesion, right? I'll give you the basic idea of important points. That's it, right? We'll not discuss everything. We have so many things. It is less common than oral leukoplakia, right? So leukoplakia is more common than erythroplakia, and most commonly it is present in males than females. Most of the prevalence figures were derived from South and South Asia. Just remember this, South Asia, right? We have two calculations over here. In USA, it is 0.09%, and in India, it is 0.02% in males, mainly in males, right? It is basically a red patch. It is surrounded by pink mucosa on the red colored velvety lesion, right? Just remember this. It is basically a red lesion, right? So it is surrounded by pink mucosa on the red color velvet lesion, right? And the etiologies are idiopathic, more prevalent in alcoholic and those who are regularly on smoke, chain smokers, tobacco chewers, and the candida infection, secondary infection, or super infection may associate with dysplastic oral mucous cells, right? So clinical features in mainly in the sixth and seventh decade of life, and sorry, male prediction is more, as I've already told you, 0.02% in Indian population and 0.09% in US, right? Mainly present in USA and India. All mucosal surfaces like head and neck, vermilion border, tongue, lateral and ventral surface, floor of mouth, buccal vestibule, soft palate, right? So it is present mainly starts from vermilion border, right? Larynx, pharynx, up to larynx and pharynx, right? It is mostly asymptomatic, but sometimes patient will feel burning sensation, right? As I've already told you, it is not in non-elevated red macule. Some cases color may result from lack or surface keratin or thinning or epithelium, right? It has well demarcated borders, and as I've already told you, surrounded pink by pink mucosa on the red color velvet lesion, right? So it is of three types: homogeneous erythroplakia, erythroleukoplakia, basically erythroplakia interspersed with patches of leukoplakia. And third one is granular or speckled leukoplakia. So in the first figure, you can see here homogeneous leukoplakia. Yeah, this part, right? This one. And in second case, let me give you an idea. Second case, it is associated with leukoplakia. So here you can see there is a white lesion associated with the red lesion. And third one is granular or speckled erythroplakia, right? So homogeneous one is, it is a bright red soft velvety lesion with straight or scalloped, well defined, well demarcated margins. In the picture you can see, and it is around extensive in size, 1.5 centimeter, 1 centimeter, 4 centimeter in diameter lesions are seen. Basically erythroplakia is mainly If large, it is more than 1.5 centimeter, and if it is small, then it is around 1 centimeter. Typically smooth surface with regular in coloration. So it is about homogeneous. That's why it is homogeneous, because it is regular in coloration. It is red color, right? Then come to your speckled or granular one. So in the picture you can see soft red lesion, slightly elevated with irregular borders. Here you can see the irregular borders and elevated lesions, elevated borders and irregular lesions, right? And granular or fine nodular surface speckled with tiny white plaques, right? Now your smooth erythroplakia. Sometimes you'll get question from that. Mainly, you'll get question from granular or speckled form. Then your smooth erythroplakia. You can see in the picture, right? So you'll get your image-based question from that. Just remember this also. Now come to erythroleukoplakia. Erythroleukoplakia is admixed or adjacent to leukoplakia basically. So it is very easy to remember that erythroplakia associated with the leukoplakia, right? So it is irregular erythematous area are seen, more frequently seen on the tongue and floor of the mouth. So in the picture, you can remember this. Borders may be well circumscribed or blend imperceptibly with surrounding oral mucosa, right? There is no need to discuss about that. So you can get a microscopic slide also. It is not of much importance, right? So microscopic variations, neoplastically, it can converted into squamous cell carcinoma, carcinoma in situ, less severe form of epithelial leukemia, inflammatory candida infection. So clinically, it can be diagnosed with the help of red, well demarcated path with no sign or of infection or inflammation. As I've already told you, it is mostly asymptomatic, right? Then your toluidine blue test, use 1% of solution applied locally. Malignant type retain the color owing to increased nuclear DNA content of tumor cell, helps differentiate malignant changes and early SCC. But otherwise, we can confirm it with the help of biopsy, right? Now it has malignant potential compared to other pre-malignant lesion in the lower cavity. So rate varies from 14% to 50%. It is much, and differentially it can be diagnosed with a chemical or thermal edematous macule, traumatic erythema, purpuric macules, right? Carcinoma of palate, histoplasmosis, ulcers, common farmers and presented as single, denture stomatitis. So everywhere you can see the red lesions. Tuberculosis are present which have rolled margins. Candidiasis lesion can be rubbed off and it is commonly seen on tongue. Area of mechanical irritation, macular hematoma, traumatic lesion. So medically, it can be managed with the help of by the removal or chemo prevention either systemically or topically by retinoid, vitamin A, C, ascorbic acid, and alpha tocopherol, carotenes or lycopenes. Systemically, we can remove it with the help of antioxidants and vitamins, mouthwash therapy containing attenuated adenovirus, and photodynamic therapy, helping patients with surgical risk, reduce reoccurrence after surgical excretion, right? Surgically, we can remove it by incisional biopsy, surgical stripping, destruction technique, clinical follow.